Okay, hi everyone and welcome. My name is Maya Schonbach and I am a clinical psychologist and the clinical program director here at Stop OCD. Today we're going to be talking about OCD and comorbidities. So ADHD, anxiety, lots more. We're going to really try and understand the overlap today. So the webinar today, we have about an hour together, and the webinar itself is around 45 minutes. And I really encourage you guys to ask questions, write them into the chat, and then we'll do a Q&A at the end, and we'll go through all the questions together. So whenever you have something pop up in your head, or even a comment, definitely write them into the chat and then we'll go through it all together. And another thing is I really recommend that you stick around until the end because I'm going to share a promo code for signing up a discount for subscribing to our program at the end. So let's get started. Okay, so just briefly, we'll go over what we're going to be talking about today. So we'll get into defining what is comorbidity, and then we'll get into specific common overlaps. So OCD and mood disorders, anxiety disorders, ADHD, tics and Tourette's. And then for each of those, we're going to dive into what the research has to show about prevalence, about the neurobiology, about the brain, about treatment. So you'll come away with some practical tips also. We'll go through some other common comorbidities and then some key takeaways. And then again, the Q&A, definitely ask away. Okay, so many people living with OCD also experience other conditions at the same time. So like I said, ADHD, anxiety, depression. And really the clinical term for this is comorbidity. So today we're going to explore what that actually means, why it's so common, and really how understanding it can help you or someone that you care about find the right kind of support. So let's start with a simple definition. So comorbidity means experiencing two or more mental health conditions at the same time. And so that might sound rare or uncommon, but it's actually very common, might even be the norm, the majority even, especially for people with OCD, because research shows that the majority of people with OCD have at least one other diagnosis, often anxiety or depression, but many others, and we'll get into these today. So again, this isn't a sign that there's something wrong with you. It really is a reflection of how complicated and how interconnected the human psyche and the human mind is and our brain is. And so understanding this overlap can really help you get the right kind of treatment instead of trying to kind of force your experience into just one label. So the title here is It Doesn't Always Feel So Separate. So really, diagnoses are useful. They help us get treatment. They help us talk about the same thing when we're trying to communicate, share our experience. But really, life rarely fits into a neat box like a diagnosis. So it doesn't always feel so separate. So you might be asking yourself, is this intrusive thought? Is this OCD or is this anxiety? Is this an anxiety disorder? Is my procrastination a symptom of my ADHD, or it could be an avoidance behavior from my OCD? And really the truth is these symptoms, they often blend together. And research backs this up. Also, the same underlying trait expresses itself in different ways across different diagnoses. So really, people say, I don't know where one ends and the other begins. And that's why many people with OCD feel like they don't fully relate to the textbook version of it, because your experience might not match one single label. And it's important to say that that doesn't make your experience any less valid. That's your experience, and it might be having to deal with comorbidities. So why does this happen? So um, first of all, many mental health conditions arise from shared vulnerability. So things like the nervous system being dysregulated, genetics, early stress, sensory sensitivity. These things all affect the way that your brain learns how to cope. And you can kind of think of it like a tree, like I have here. So all of the symptoms, here I wrote, yeah, like the disorders, but it's really the symptoms also that we see. Things in the compulsions, distractibility maybe, panic, anxiety. These are kind of like the branches, but then underneath, you see that they're all from the same root system. So again, it's not that you're too complicated, it's that your system, it's working in overtime or overdrive to manage so much all at once. Okay, so when people hear that they have multiple diagnoses, or if you suspect that you do, it really can feel overwhelming. Maybe like you feel like you're broken or too complicated. Maybe the hopelessness that the treatment will never work. But here we can try and reframe it. The comorbidity doesn't mean that you're broken. It means that your experience, it's layered, like here in the image. So it's not about fitting kind of into a box. It's about understanding the system as a whole so we can treat the whole person, not just the label. And then that's why it's important to see the overlap clearly, because we also want to try and simplify the pathway forward. Parsimony, the idea of the simplicity being often helpful. Okay, so now let's get into what research has to say about common comorbidities. Sorry, okay. Okay, so this is a graph from a 2021 meta-analysis. I have the citation here, conducted by Sharma and colleagues. And it's really one of the largest reviews to date about OCD and comorbidities. So this graph, it's a little overwhelming. The study actually was very overwhelming. They analyzed over 100 different studies. To, it was 16,000 people that they have with OCD from all of these different studies. And they analyze them to see how often different comorbid conditions show up. So what you can see here, first of all, is at the top, it's kind of small to see, but any psychiatric comorbidity here, over 60%. So this is shows that the majority of people with OCD in this study, or in all of the studies, they saw the majority of people have at least another diagnosis or meet the criteria. And what we see here is that the most common is mood disorders, especially major depressive disorder, and then anxiety disorders and lots of other disorders as well. And really, this gives us a clear picture that comorbidity in OCD is very common. And it's important to understand this. And so let's get into we'll dive deeper into some of the most common ones now. So I said we'll talk about the prevalence, the neurobiology, and the treatment of each one. And again, ask questions if you have any. Okay. My water's leaking. Okay, so OCD and mood disorders. So examples of mood disorders are things like major depressive disorder, what we call what we call depression, bipolar disorder, so having also episodes of mania as well as episodes of depression, or persistent depressive disorder or dysthymia. Those are also common. And when we talk about OCD and mood disorders showing up, they're not just, it's not really a coincidence that they show up together. These conditions, they deeply affect each other. So living with constant intrusive thoughts and feeling the need to repetitively do compulsions, these are things that take a toll. Over time, they really can wear down a person's their energy, their outlook on life, their sense of hope, their mood. These are all symptoms of depression. And at first, it might seem like the compulsions that they're helping, because first they do give some element of relief, some sense of control, but eventually they lose that effect. And when that happens, it's easy for hopelessness to set in. And we often see symptoms like um, low motivation, isolation, a really deep sense of guilt, and not just about the OC, but about the way that of feeling stuck inside of it. And really, that's why it's so important to treat both of them, both the mood and the OCD, because left untreated, they can reinforce each other and then make it harder to move forward in treatment. Okay, so like we saw in the meta-analysis study, in that review, when it comes to comorbidities, depression is the most common with OCD. And so they found that MDD, or major depressive disorder, appears in about 40 to 60% of cases with people with OCD. It's showing that about half or even more than half of people with OCD may have a comorbid depressive episode at some point in their lives. That's a lot. Um, and then other mood disorders, things like dysthymia, bipolar disorder, like we said before, they're less common, but they're still clinically significant. And then it's also important because they make the presentation more complex or maybe even more treatment resistant. And this is also, we also know that this comorbid depression is more likely to show up in adults than in children with OCD. And this is also interesting because maybe that reflects how the OCD can have a chronic kind of emotional toll that the OCD takes on us over time. Um, and so that might be why it's showing up more in adults than in children. And then it's important to say that this overlap really affects functioning. So it leads to more severe OCD symptoms. It leads to poorer response to treatment and a significantly greater impairment in daily life. And so this really is why it's so important to look at both, treating both of these disorders, not just the OCD alone. Okay, so in terms of the neurobiology, when you have both depression and OCD, the brain, it's a little bit of a different story than having just OCD alone. So one of the key areas is the medial orbitofrontal cortex, or the MOFC. And so this is a key brain region that helps regulate emotion and control. And so research shows that people with both OCD and depression, this area has more structural changes, leading to it function maybe not as effectively. And then another important, interesting part is that the brain's communication pathways also shift. So there's more connection between the amygdala and the insula, and those are areas that are involved in emotional intensity, threat detection. So that's maybe leading to more emotional overwhelm. And then there's also less connection to the ACC, or the anterior cingulate cortex. And that's an area that normally helps us monitor and regulate our reactions. So that could lead to weaker self-regulation. So maybe these are the changes that might help explain why OCD symptoms feel kind of harder to control, or they're heavier, or maybe emotionally overwhelming when you also have depression present. So it's really not just that you have more symptoms, it's that the brain is really and the brain systems are interacting differently. And then again, the depression might be amplifying emotional brain loops that are already active in the OCD. So how does this affect treatment? So when someone is struggling with both OCD and depression, we have to consider the interaction and then really treat the way that it works for the person. So importantly, SSRIs, or selective serotonin reuptake inhibitors, they're the first line treatment for both OCD and depression. So that's helpful because it's the same medication. However, there is an important distinction that OCD typically requires higher doses, much higher than depression. And this is shown in multiple studies, and it's really the standard clinical guidelines. Um, and in terms of psychotherapy, behavioral activation, that is the gold standard for depression. And that's really what you do to help people kind of begin to move again. So it's not necessarily working on their rumination or their intrusive or obsessional thoughts, like it's more about taking small, kind of meaningful actions that eventually shift somebody's mood and kind of rebuild their motivation. And it's really important when someone feels hopeless or paralyzed. And so if the depression is severe, then you typically need to start there. So in OCD, I wrote it here, but ERP or exposure and response prevention, that's the gold standard of treatment. And that has to do with being exposed to the triggers that trigger your obsessional thoughts and then preventing yourself from doing the compulsions. From response prevention, you prevent yourself from responding in the compulsive manner. And so sometimes if someone is struggling just to get out of bed, that they can't even go start an exposure, the ERP might feel impossible at first. So in these cases, we really need to focus on first lifting the depression, maybe just enough, using a combination of medication, structuring in their daily life, behavioral activation, and that we need to focus on that first so that the person can fully engage in the OCD treatment. And then that being said, once the person has gained a little bit of energy and motivation and momentum, then you should start the ERP. You shouldn't delay the ERP for too long because it's best that these conditions are treated in parallel. That really treating both together really does lead to better long-term outcomes. So even treating them, if they're staggered slightly, that leads to better outcomes long-term. So yeah, treating one, ignoring the other, that could lead to relapse or partial response. So really, it's important to treat them in an integrated manner, but that's also flexible, but definitely not treating either or. Okay, so now let's look at OCD and anxiety disorders. Okay, so OCD is classified separately from anxiety disorders. So that's how they're classified, but they actually typically feel very intertwined. So a lot of the driving forces behind OCD, things like fear and hypervigilance, urgent need to reduce distress, these are also things that are central to anxiety and anxiety disorders. And then anxiety often amplifies the OCD symptoms. So especially for somebody that's struggling with uncertainty, which is core to OCD, or with catastrophic thinking and anxiety, leading to the what if, what if, what if. And then, for example, when social anxiety is involved, people might go to great lengths to hide their compulsions, secrecy, masking, maybe not because they're suffering from the OCD, but maybe because they're afraid from the social anxiety perspective of what others might think. And then, for example, with panic disorder, panic symptoms can also intensify OCD. So maybe compulsive checking for fear, having a panic attack, or maybe having avoidance of certain triggers for the panic. And so we can diagnose these conditions separately. It's very, again, helpful to understand how they overlap and reinforce each other. So, okay, again, we see strong patterns of comorbidity. So generalized anxiety disorder, or GAD, shows up between 12 to 20% of OCD cases. Social anxiety in 10 to 17%, panic disorder in 10 to 12%. So that's a huge percentage. And again, it's not uncommon for people to meet criteria for multiple anxiety disorders in addition to the OCD. So in one study, 9% of people, that's almost 1 in 10 people, of having OCD had 4 or more anxiety diagnoses. It's a lot. And it's important because the more anxiety overlap that someone has, the more likely they are to have more serious functional impairment. And then also maybe less likely to seek help. And also important to say here is that we see comorbid anxiety disorders more common in pediatric OCD than in um, uh, mood disorder. Sorry, we see anxiety disorders more common than mood disorders in pediatric OCD. In adult OCD, we saw more common mood disorders. So in terms of neurobiology, there is a lot of overlap. So especially in circuits with fear, with emotional control, emotional regulation, and also control. So both conditions, they show dysfunction in the brain's fear learning and the executive symptoms, and I say it here because of the prefrontal cortex. So specifically the connection between the prefrontal cortex and the limbic regions, which are further back. And really, these connections make it harder to regulate your distress once it's triggered. So studies really consistently show that things like the regions like the amygdala, the insula, the anterior cingulate cortex, like the ACC that we already talked about, they're often overactive in OCD, but also with anxiety. And these are areas that are responsible for detecting threat, for monitoring internal tension, for triggering emotional arousal. And so if these areas are overactive, then, or you're kind of in overdrive and you feel more fear, more tension, more emotional overload. And then it's also about not just about the individual regions, but also about the larger systems of the brain. So things like the default mode network, that's like linked to things about self-focused rumination, intrusive thoughts in your head, and then also things like the salience network of like looking outwards at different stimuli and then flagging certain ones as threatening or not threatening. And then when these networks are disrupted in OCD and in anxiety, it makes it harder to shift your attention and then to disengage from the worry, or really to reassess what's actually dangerous. And so again, maybe the content of the symptoms might look different between OCD and anxiety disorders, between the compulsions and worrying. The brain is really struggling with the same underlying regulation problems. So there's a huge connection there. And then in terms of treatment, again, we need to think flexibly. So ERP, it's again the gold standard exposure and response prevention for OCD, but typically we need to adapt it when we have another anxiety disorder that's comorbid. So for example, if someone has GAD or generalized anxiety disorder, we might need to go beyond the ERP to include things like worry management strategies. So things like cognitive diffusion techniques or worry postponement. That's when you maybe set a time later in the day where you're going to set 20 minutes and specifically use that time to worry. And then throughout the day, whenever you notice yourself in a worry loop, you say, no, I'm going to do it later today at 6 p.m. or whatever. So different techniques or metacognitive techniques that you can add to the ERP while you're doing exposures. And then for so that's for GAD, and then for panic, it's important to distinguish between the panic triggers and the obsessions. So things for panic triggers, we do things called interoceptive exposure. So things that we deliberately bring on the physical sensation. So you can, if it's about feeling suffocated and worried about feeling choked, you could, like me, wear a turtleneck, wrap a scarf around your neck, And typically we do this in the clinic, so you feel safe with a psychologist or with a therapist. Um, and so that could be helpful. And just as important as doing the traditional exposure and response prevention for the OCD. And when social anxiety is also comorbid, typically we blend ERP with the social exposures. So that's also definitely happens when people are maybe fearing judgment. So you're kind of trying to work both on the intrusive thoughts and kind of the social avoidance or the avoidance of the social risk. So, again, research shows that the more anxiety someone has, the earlier the onset is, the earlier their OCD tends to appear, the more severe their symptoms are, and the more complex the treatment becomes. But that doesn't mean that the outcomes have to be worse. It just means that we have kind of more puzzle pieces to work with. And so again, some clients don't fit a box perfectly. That's okay. Comorbid anxiety, it's not a barrier to treatment. It's just a clue that helps us kind of personalize the approach and then connect with what the client really needs. So let's move on to OCD and ADHD, also another common. Okay, so OCD and ADHD, they might seem like complete opposites. One is about control, the other one is about distraction. I tried to show it in this image, having like sticky notes everywhere and being that, but then having like a very neat notebook. Um, and yeah, someone might struggle to focus because of their ADHD, but then maybe they hyper focus on their compulsions in their OCD. And then it's also common to see avoidance that might look like procrastination, but it also might be fear-based. So it's very complicated and again layered. And like I wrote here, executive function issues, difficulty starting, switching, finishing tasks definitely could be in both. And treatment really does need to address both, especially including executive function challenges, and then also the compulsive thought loops. Okay, so in terms of prevalence, so it shows up ADHD in about 12% of adults with OCD and up to 25% in pediatric OCD. So that's huge. And when ADHD and OCD happen together, it actually often makes the OCD more severe. People tend to have more persistent symptoms, greater impairment, poor long-term outlook. All of this is if the ADHD is left untreated. And so, again, like I said, a big reason for this is both conditions affect this executive functioning. So when they overlap, those challenges can kind of be multiplied. So let's talk about the executive functioning in the brain now. So this is very interesting because both disorders involve something that we call the frontostriatal circuitry dysfunction. So that's kind of the brain system that's responsible for things like focusing, for planning, for controlling impulses. And then here's what's interesting is that in ADHD, this symptom tends to be underactive. So that leads to distractibility, the impulsivity, having difficulty having sustained attention. And then in OCD, it's actually overactive. So that fuels the obsessive thinking and all the compulsive behaviors. And so even though you have these differences, both conditions really involve this executive dysfunction, especially when it comes to inhibition of control. So kind of in other words, we're saying that these are both disorders that you're struggling with regulating what the brain is doing, but it's struggling in different ways. And then when it's together, it's even more interesting. It's kind of we don't know. And it's, I think, very different per person. Um, okay, so let's look at this brain diagram that's done from a study in 2019 by Kappa and their colleagues. So on the left side, you see the brain with during OCD. And so here again, it's the corticostriatal thalamic loop. And that's in OCD, like we talked about already, that's overactive. Um, Talking about processing thoughts and actions. And then it can lead to being overactive, leading to intrusive thoughts, and the strong drive to perform compulsions. And then on the right side, we see the brain changes in ADHD. And here you see the reduced activation, the hypo, in the prefrontal cortex, areas like the striatum, the nucleus accumbens, basal ganglia. So these are all areas that help with planning, focusing, motivation. And when you're underactive, then you're distractible, impulsive, you find it difficult to stay on track. And so again, this is just interesting to see where the similar areas overlap. OCD running kind of on overdrive and ACD running on low, but they're both rooted in the same control area and they're wired differently. So in terms of OCD and ADHD and treatment, because the brain is so different, it kind of feels like you're getting pulled in two different directions, but it's important to treat them again together. So the medications are different, but they actually complement each other. So the SSRIs, like we said, that's the standard treatment for OCD. They kind of help by calming down the brain's overactive network that we just said, that drives obsessions and compulsions. And then for ADHD, we treat that with stimulants, things that actually boost and increase the prefrontal cortex activity that was hypoactive. So those to improve the attention and the impulse control. And so there has been some concern that stimulants, the medication for ADHD, could make OCD worse. And that is possible. I did want to say this here. But research shows that overall this effect is very rare and it's mostly actually just anecdotal, like very it's more from case studies as opposed to larger scale studies. And actually recent studies show that ADHD treatments, so stimulants in comorbid OCD cases can actually reduce the OCD symptoms, and not worsen them. So that's even better. And so that could be because when your attention improves, maybe you're actually better able to learn and apply your ERP skills. So maybe that it depends if they're in treatment or not. And then also on the other hand, if ADHD is untreated, it's also been shown that it diminishes the response to ERP. So it's important to do both. And that I wrote that it can enhance SSRIs could enhance attention via neuroplasticity because there's research that shows that treating OCD with SSRIs and ERP through the BDNF factor, it's a brain factor, and neuroplasticity in our brain, which is how our brain is able to change and form new connections in certain areas of the brain. And that actually helped improve attention and processing speed actually in the studies. And so really what's clear is that it's important to treat both symptoms. So treating only one leads to poor outcomes. For example, a study found that patients with both OCD and ADHD had lower response rates to SSRIs. They had a higher risk of relapse than just the OCD alone. And so it's important to treat both disorders again together, and treat them with medication and the CBT techniques that are tailored to each. Okay, let's move on now to OCD and tics or Tourette's. Okay, so tics and Tourette's are really relevant when we're especially working with pediatrics. So early onset OCD, so children, adolescents. Um, and it's important to distinguish them. So tics and compulsions, they're not the same, even though they can look similar maybe on the surface. So tics, they're typically involuntary motor, maybe vocal movements. So the blinking is common, so that's why I put this picture. It's kind of tried to show someone blinking. Typically tics are fast, they're repetitive, but really they happen without a clear thought or without a fear behind them. And then in contrast, so compulsions, they're typically performed in response to intrusive thought or an obsession. And they have a specific purpose. And the purpose is to reduce distress or to prevent something bad from happening. And so both tics and compulsions can coexist, and that makes it kind of hard to tease them apart. And so also it can make diagnosis or ERP, exposure and response prevention, more complicated. So like here in the picture, maybe is the child blinking repeatedly because they have a tic, or is it maybe part of a ritual? Maybe blink 5 times because I had a certain intrusive thought, for example. Um, and so basically we need to look closer at the function of the behavior. And then also the DSM, the Diagnostic and Statistical Manual that we use to classify and diagnose, it actually includes a tic-related specifier for OCD. So it really recognizes and highlights how common and clinically relevant this overlap is. So here we'll talk about the treatment soon, but ERP, fortunately, research shows that it's still effective in treating OCD even when you have tics, but you could adjust it. We'll talk about that shortly. So again, looking at the large scale review, we saw that about 14% of people with OCD also meet the criteria for a comorbid tic disorder. It's more common in males and in early onset OCD. And tic-related OCD does have some unique features. So it typically includes more motor rituals, a strong element of just right sensation. So the need maybe for balance or for something to feel just right in a certain way. And also often lower levels of insight into the logic and the reasoning behind doing these specific behaviors. And like I said, again, it's really important to clinically distinguish between involuntary tics, like blinking, for example, like we said, again, non-goal directed movements or sounds, from the compulsions, where they're more intentional, goal directed, with the goal being to reduce the distress or to prevent something bad from happening. So again, in terms of neurobiology, both tic disorders and OCD, they show disruptions again in the CSTC, the corticostriato-thalamocortical loop. But in tic disorders, this disruption is specifically tied to the motor and sensory motor regions. And that kind of helps explain why tics feel so physical and why they're so hard to control. And right, this is important to say that many people with tics describe, it's called a premonitory urge. So it's kind of this buildup of tension or discomfort that you can only relieve it by performing the tic. And then it's kind of described as an urge-driven loop. And then we say that that likely involves not only this motor area, but also things like the insula, which helps us processing internal sensations, which is also involved in OCD. And then I also want to talk about Tourette's, which is also a neurodevelopmental condition, typically starting in early childhood. And that also shows a strong genetic link, and it's seen often in families with early onset OCD. So, like I said, the good news is that ERP is still definitely effective for OCD, even when tics are present, but we can adjust it. So first, to differentiate, like I said, differentiate if the tic is ritualistic or it's as a compulsion or it's tic. And we again differentiate that based off of function. So if there's like a premonitory urge, like the buildup of tension, or it's behavior that's driven in order to reduce distress caused by an intrusive thought from an obsession. And studies found that comorbidity of OCD and tics do predict a poor response to medication alone, but that didn't have an effect on the response of CBT. So again, ERP or exposure and response prevention remains the gold standard for treating this. And then in some cases, it's kind of helpful to bring in behavioral therapy for tics. So things like habit reversal training could be added. And these tools from this type of treatment can work well in combination and alongside the ERP. And here, treatment doesn't need to follow a strict order. Really, what's important here is to focus on what's causing the most impairment and to start treating that. So is it the obsessive fears? Is it the compulsive rituals? Or is it the tics? And then once you know that, then you can build a plan according to the client. And really, I wrote this here because the first step for treating both is to distinguish between the tics and the compulsions. And just that step alone can be really powerful and really helpful because it really improves a person's insight. And then it also helps the ERP become more targeted and more effective as you're treating the OCD. So let's just briefly do an overview of a few other common comorbidities and then we'll sum up. So OCPD, or obsessive compulsive personality disorder, it shows up in about 17% of OCD cases, but it's different than OCD. So OCPD, the personality disorder, talks about having traits like perfectionism and rigidity, and that's often seen as part of a person's identity. And that's not something that they want to change. And we call that egosyntonic. And that's different than OCD, where it's the person recognizes that the compulsions and the obsessions that they have, they're not something that they want to be doing. They just feel like they have to do it. And we call that ego dystonic. And the idea of ego syntonic, that the person in the personality disorder, that it's part of someone's identity, it can make it actually harder maybe to treat it. And then in terms of autism spectrum disorder, or ASD, that shares features with OCD in terms of having a strict maybe routine, repetitive behaviors, social communication differences sometimes, and autism has an overlap of 6% of comorbidity with OCD. And again, in terms like with tics, the key difference in terms of the repetitive behaviors here is the function of the behaviors. So whether or not it's for OCD, again, to reduce the distress caused by intrusive thoughts, or for ASD, in this case, it's more for a sensory purpose or for having structure. That's typically more for autism. And then body dysmorphic disorder or BDD, that um, we see that in about 3% of OCD patients. And that can have overlap in terms of compulsive checking, maybe compulsively checking the mirror or the body. Avoidance is also common here, and again, preoccupation with appearance, with perceived flaws, and that can be overlap, especially with people that have appearance-related obsessions. And then eating disorders and substance use disorders are also worth noting. They might seem separate or can emerge as coping mechanisms, not healthy ones, but coping mechanisms. But substance use, for instance, is present in almost 7% of cases. And that, again, can also further complicate treatment. So these are also very common overlaps. Okay, so let's do a quick overlap here. Not overlap, wow. Key wrap up here. So there's a few key ideas that I want you guys to take away with you. So first and foremost, it's not unusual for people with OCD to also have other diagnoses, another diagnosis, or other traits. Really, the overlap can shape your symptoms, how they appear, and really how we approach treatment. So it's important to look at these together. Anxiety disorders, mood disorders, those are some of the most common overlaps, but they're not the only ones. We also talked about today ADHD, tics, autism spectrum disorder, other areas. These affect attention, emotion regulation, social behavior, and then in turn, it also affects treatment needs. And really, I think my bottom line takeaway is not to get lost in labels. It's really important to recognize that every person's kind of experience or their presentation of OCD and or other disorders, it's really unique. And so when we're talking about treatment, it's really important to be flexible with this and to have really a full understanding of a full picture of the person that is in front of us. And then we can make choices that are effective for that person. So I want to just show you guys some resources that we have from Stop OCD. So you can check out our website, stopocd.com. And we also, I really encourage you guys to follow us on social media. It really is a great resource, great opportunity for community. Ask us questions or just follow along. Great center for information and for treatment options. And so, like I said at the beginning, here is a $100 discount for the first month of our program of Stop OCD. So you can use the promo code PROWEB100. And if you have any questions about the program, definitely send an email to support@stopocd.com. And if you have any more clinical questions, we can jump into some now, or if you feel that you want to ask something more privately, you can send me an email to maya@helpingminds.com. So I see we have some questions. Okay, we had a comment. Thanks. Any questions? I'll wait a couple minutes, but um, yeah, if you don't have any questions, definitely don't hesitate to email me. You can also write comments if you want. All right. Okay, if there's no questions, then we can definitely end today. It was a very intense. Oh, here we have a question. What's the best way to help a child with autism who shows symptoms of OCD, but the parent doesn't want medications? Okay, that is definitely a big question. So, first of all, we can go back to the slide about autism. I think I only had one line about it. Um, yeah, but the key here definitely is to understand, first of all, the OCD symptoms. Um, I wonder if are you talking about, I think it's important to understand if we're talking about the ritualistic behaviors, which can look like OCD symptoms, but maybe it's important to understand what's the purpose of these symptoms. So, if they have to do with reducing intrusive obsessional thoughts, in that case, that is definitely OCD symptoms. I don't know, definitely, but those would be considered OCD symptoms. Um, and if the person doesn't want, the parent doesn't want medications, that I would suggest working with a therapist, maybe on exposure and response prevention, because that the autism doesn't need to necessarily hinder the ERP, the exposure and response prevention, and that definitely is the gold standard for treating OCD symptoms. So I would first try to understand the underlying um, symptoms. So yes, so now the clarification is the routine, ritual, always wanting school bag placed in a certain way, or water bottle must face a certain direction. So again, it sounds, again, from the two lines that I'm hearing, it could be like it sounds like OCD symptoms, but it definitely could be elements of autism, because the routine, the rigidity, the repetitive behaviors, those like the strictness, those are definitely elements also of autism. So it does sound like a deep overlap between autism and OCD. But again, like I said, it's important to understand and tease apart the functionality of those behaviors. So if the child is wanting the school bag placed in a certain way, or the water bottle in a certain direction, I would ask them, like, say, are you doing this because it's reducing some distress of maybe of fearing something bad happening if you don't do it? Or is it something that it needs to be a certain way because that's how I like it? Those are part of the autism. And again, it's hard to understand that, especially with children. So, but I would try to understand maybe more um the functionality. Um, Somebody wrote high functioning autism and emotional overwhelm, rejection dysphoria in adults, addressing in couples therapy. Um, and you're from Portugal. Very cool. Um, is there a question there? Well, thanks for sharing. All right. Oh, so the other question was the child is speech delayed too. So when she asks about why the function of behavior, she does what she does. She says she likes it that way. Maybe try asking what would happen if we change it, if we don't do it that way. What do you feel? Um, and then see if she fears that something bad is going to happen. I feel like it really is about parsing that apart, trying to understand the function, the understand, because it does sound like it is an element of the autism. Um, and then in that case, the ABA would definitely work. I'm definitely not an expert in autism, but that would be something that I would lean towards there. Um, one person neurological. Um, so the question was high functioning autism and emotional overwhelm, rejection dysphoria in adults, addressing in couples therapy. It first of all sounds like a lot, but maybe trying to get to, like I had with the slide about the tree and the roots. It sounds like maybe there are underlying things that are common to all of these things. So emotional overwhelm, high functioning autism. So maybe an element of difficulty in communication, an element of emotional sensitivity, of rejection dysphoria. I don't know what you mean by that, but maybe trying to understanding the underlying roots of what all of these different um, kind of labels that you have are, and then trying to get to kind of the core, maybe elements of it if you're working on that in couples therapy. But it sounds very interesting. Um, all right, everyone, we are out of time. Thank you so much. Um, great. I hope that you guys have a great rest of your day and join us for our next webinars. Bye, everyone.